Well, welcome everybody to tonight's webinar or today's webinar, whenever you may be watching this. My name is Carla Cohn, and I am a general dentist. I'm located in central Canada in Winnipeg, and I have spent the last 34 years of my practice taking care of the kids in my practice. And that's what I'd like for you to be able to learn how to do as well. So I get to do dentistry in my office. I am now at Kids Sleep Dentistry Winnipeg, which is an operating room based practice. We see all of our kids under general anesthetic. I spent about 30 years seeing awake kids. So I'm right there with you, whether you're here to refresh what you already know, to update what you know, or to start off from scratch. I'm here to provide you what the latest in the pulpal therapy strategies. We're going to talk about vital pulp therapy primarily for primary teeth, with a pun intended. And we are also going to talk about restorations of pulpally treated primary dentition and how to properly do that. So if you would like to get hold of me, and I'd love to hear from you, that is my email address, info@litsmileacademy.com. Feel free to reach out with any questions or comments that you may have, so long as they're nice ones. And I'd love for you all to follow me on my Instagram. That's at Kids Dentist Carla. I am really close to 8,000 followers, and I know there's 2,100 of you out there registered today. So if a few of you can click follow and share and like and all of that fun stuff, I would love that. It'd make my night, not just talking to you tonight, but pushing me up to 8,000 followers would be really sweet. So go ahead and do that. I'd love to have you. Below that is my Lit Smile Academy website, and that is my continuing education platform. And I've got some things coming up on that Lit Smile Academy that I will tell you about in the coming slides. So again, thanks for joining me. And we are going to tell you about my disclosure. So I know that I have just been told that this is my number 18 webinar for Viva Learning, and I've done lots of other webinars. So if you've seen me before, you've seen this disclosure slide before. I do speak on behalf of several different companies, and I do use all of these products that are pictured here and more. So if you see me speaking about any of these products, you got to know that I use them. I do talk what I use, and I use what I talk about. So you can rest assured that these are all products that you can use and get the best results from. So that's my disclosure in general, but tonight's disclosure is Bisco has provided educational support for tonight's webinar, and many of the products that we use for pulpal therapy are from Bisco. So I am here to tell you about them, how to use them for the pediatric patients in your practice properly, and what good you can do for yourselves, your team, and your kids by using these products and doing pulpal therapy properly. And without further ado, we are going to talk about pulpal therapy, the why, the what, the when, the how, all of the things that you need to know. So if you've missed out on any of my websites or my contacts or my Instagrams or my emails, they're scattered throughout these slides as well. So do feel free, as I said, to reach out to me. I think it's one of the coolest things to hear from the people that have attended my webinars and to hear where you're from and what your interests or concerns or questions are. So I do sincerely mean it when I say that you should reach out to me. So why do we do pulpal therapy? And after all, these are just, what do we often call them? They're just baby teeth. Well, they're not just baby teeth, first of all. And second of all, even if they were just baby teeth, that is a very bad excuse for some dentistry on some just baby teeth. So we don't want to do that ever. They're not just baby teeth. These teeth stick around for a long, long time in our kids' mouths. They start off in our children's mouths when they're about 6 months of age. and they don't exfoliate the last one until they're between about 11 and 13 years of age. So they're not baby teeth, they're kids' teeth. They are critically important for all of the things that kids need to do. Smiling, eating, chewing, space maintenance, all of these critically important things that happen while the kids are growing. And so it's very important that we take care of them properly and that we as dental professionals can provide the most up-to-date, effective, efficient procedures, materials, treatment that is out there and available to them. So what is pulpal therapy? What do we mean when we talk about pulpal therapy for primary dentition? And in this photograph, which we'll talk about towards the latter third or so of this webinar, I'll talk about pulpotomies, which is one of the common vital pulpal therapies and one of the ones that has changed most drastically in the last several years. So if you're still doing old school pulpal therapy that you learned 20 years ago, even 10 years ago, the times have changed and you will be happy that you have tuned in tonight. So vital pulpal therapy, our goal is to preserve and to promote pulp vitality. So to keep the tooth alive after injury. What does that injury mean? Injury can be a carious insult. So like in this first primary molar where we have caries on that tooth, we have a carious injury, a carious insult. It can be a traumatic injury or traumatic insult, which could be from either the child having an accident and fracturing a tooth, so a trauma that way, or it can be a traumatic insult from our operative procedure. And sometimes we can mechanically expose the pulp without intending to, and then we need to go ahead and do some vital pulp therapy for that tooth. Now, sometimes we have operative procedures that compromise the pulpal health. So we have either a handpiece that is too hot and it heats things up and it makes that pulp fry, or we have a light. A lot of our lights have high intensity now. And so those lights can cause a problem as well when we are doing our pulpal therapy. So we need to be aware, we need to be comfortable, we need to be confident in doing this pulpal therapy so that we can keep our teeth healthy in our children's mouth, we can keep them without injury, we can keep them without pain. And so we talk about that vital pulp therapy. So our goals of the vital pulp therapy is ultimately we want to maintain that pulpal function, and vital pulp therapy, it means in a vital way, and we want to prolong the longevity of that tooth so that we can have that tooth in that child's mouth until it's ready to exfoliate at the ages that we see on this chart. So at the ages of between 7 to 8 for a maxillary central incisor, between the ages of 9 to 12 for a maxillary second molar, so that we have that ability to maintain that tooth in the child's mouth. That's our ultimate goal, what we want to do. Now, when we look at pulpal therapy, we want to look at how we do pulpal therapy, which is what this is all about tonight. This is all about how we're going to do pulpal therapy, how we're going to diagnose that tooth properly and effectively, how we're going to choose the right pulpal therapy procedure, because there's several different pulpal therapy procedures out there, and how we're going to choose the right material for that pulpal therapy. And then ultimately, as I said, we're going to talk about restoration of these pulpally treated teeth. So a bit of a tall order for the short hour that I have together with you, but here we go. Now, some of you may have tuned in to a previous vital pulp therapy webinar that I have done. I have one that is on Viva Learning now. I'm not sure how long. I think things are kept in the archives of Viva Learning for quite some time. And so what's different now from a year ago is what we are learning and what we have learned in this review. So this is the use of vital pulp therapy in primary teeth for 2024. And we're just at the beginning of 2025 right now. But in this article that was written are all of the recommendations, the clinical guidelines put through in this article that are adopted by American Academy of Pediatric Dentistry is where this journal is from. So this is Pediatric Dentistry Journal. So Doctors Cole and the team here, and there's quite a few that are very well-renowned experts in the field, and they have done a meta-analysis. They've done a systematic review on vital primary teeth pulp therapy. And now we have the recommendations that are current. So if you're familiar with what we were talking about a year ago and slightly before that, you'll see that many of these recommendations are reinforced with this work that has been done, and we have more direction on which way to go. So I'm going to spend a fair bit of time going through this review that they have done and really distilling it into something that makes it workable for us in our practices that we can understand. So key to this diagnosis and the choosing of the procedure and the choosing of the material is this flow chart from this article. Now, I've gone, you don't need to read all of the words because I'm going to break it down bit by bit. But what you do need to know is what we start off with in this chart and where we're ending to is starting off with the healthy child that has deep caries in a primary tooth. And then the end of this diagnosis and the goal and the treatment is to have a same-day final restoration, which can be a filling or a preformed crown. So I'll take you along this pathway throughout tonight's webinar and go through what it is that you need to do. Sorry, dogs are barking. What it is that you need to do at each point to diagnose and to determine what it is that you're going to do. So we go from that healthy child with the deep caries in the primary tooth, and the first thing that we need to do is diagnose the pulp. We need to diagnose whether that's a vital pulp or whether it's a non-vital pulp. So we need to, for the purposes of what we're studying tonight, and what I'm talking to you about tonight is we need to know that we've got a vital pulp, which indicates a normal reversible pulpitis, and that we can go ahead and do our vital pulp therapy. If we go to the right side, to your right side of your screen, and we have a non-vital pulp, then it's an irreversible pulpitis or necrosis. And the methods that I'm going to talk about in this webinar are not going to be what you're going to be doing if we have a non-vital irreversible pulpitis or necrosis. So pulpal diagnosis is the key. And if we get that pulpal diagnosis correct, then almost everything that comes after that is going to flow through the chart very easily. If you get the pulpal diagnosis wrong, then doesn't matter what it is that you do on the vital pulp therapy, you're going to wind up with a problem. So when we do the pulp diagnosis, the first thing that what we do, and I ask my patients, we know that the child has deep caries, or we know that the child is coming into the office with pain or calling the office with pain. So we start to ask questions about that pain that child has. Do we have pain that is induced? So that means that do we have pain that is caused by something? Do we have pain that child has when they're eating something? Or do we have pain when that child is brushing their teeth? Or the next question is, do we ask, does your child have daytime pain? Does it hurt during the day versus nocturnal pain? After that, we're going to ask if the pain is transient. Does the pain come and go? All of these things that we're asking the parent or the child are all things that are going to give us clues towards the diagnosis, information towards the diagnosis. Is the pain relieved? So if the child takes any medication, analgesics, is that pain relieved? And all of these things that we're asking the child or we're asking the parent are subjective things. So these are things that the child is feeling. Now, if we are asking the child a subjective thing and we have the child that is giving us the answers to the questions that we're asking, and we have a 2-year-old or we have a 3-year-old child that's giving us answers to these questions, we maybe might not have a very accurate source of our information. So remember that it is subjective when the child is answering, when the parent is answering, and that this does not provide us with a definitive diagnostic tool. I don't like to use the term, this is giving us clues to the answer to the puzzle, but it really is giving us clues to the answer to the puzzle of what is happening with this tooth. So very subjective, doesn't provide definitive diagnosis because our answers are not definitive. But the first few questions that we ask them, is the pain induced? So is it caused by something? Does it hurt when you're chewing? Does it hurt when you're brushing your teeth? Does it hurt when you have something hot or something cold? Does it happen during the day or does it happen during the night? Is the pain transient? Does it come and go in a short period of time? And is it relieved by analgesics, acetaminophen, Tylenol, Advil, etc.? So these are the clues that we ask our parent, and we will ask the child if the child is a good historian. So age, as I've said, is a barrier to accurate history. Kids are typically poor historians. Now, this totally depends. I'm not going to get a 2-year-old in that's going to be a great historian. Sometimes I'm not going to get a much older child in that's a good historian either. So the history that a child is giving us is typically not as reliable as a history that an adult was going to be giving us. Now, think about this. When the adult is giving us the history, so the parent or the caregiver is giving us the history of the child, they're telling us what they think the child is feeling. They're not feeling what the child is feeling. So it's also another barrier to an accurate history. And sometimes when we have our kids in our practice, their pain is so chronic that they may not be able to differentiate what the chronic pain is or what is their actual baseline. So you have these kids that come in, let me clarify and explain what I mean by that. You have these kids come in that have early childhood caries. So they've got a tooth that is erupting at the age of 6 months of age, and that tooth is erupting. As it's erupting, it's decaying. And so that child has really never, ever known what a healthy mouth feels like. So when we ask them if they have pain or if they report pain, it is a fine line for them to differentiate between what's chronic, what they think is normal versus what is actually pain, what's acute pain. So it's a tough thing for us to get a good diagnosis on. So you have a kid that comes into the practice that looks like this. So these are primary maxillary incisors, deeply decayed. And you've got to think that you have something hot or you have something cold, and that is going to hurt. You bite into some ice cream, that's going to hurt. But as I just said, if they've had this situation where they've had deep decay in their teeth for all of their lives, they often cannot differentiate. Same thing with the primary molars that you see here. You've got a fractured tooth. You know that you and I, as dental professionals, if that was in our mouths, we would be acutely aware of that. As a child, 2, 3, 4, 5 years old, you're not so much aware of it. This child came in and parents said, no, they don't complain of any pain. And it's sad and terrible that this happens, but you got to wonder how could that not hurt that child. Very often I'll get a child that comes in and primary teeth have been hanging around and the parent hasn't dealt with it, and sometimes the referring dentist hasn't dealt with it. So lots of reasons why this can happen. The parent may not have dealt with it because they don't know any better. The dentist may not have known any better, decided that primary tooth that's hanging on there, that root is just going to exfoliate, and then they don't have them come in until it's actually a problem with the eruption of the succedaneous tooth. So it's a concern when we have the history that is not accurate. Much more accurate when we're looking at our pulpal diagnosis is to look at the clinical diagnosis of the soft tissues. So soft tissues don't lie. When we look at our soft tissues, in order for a tooth to be properly treated with a vital pulp therapy, the soft tissues must be normal. But on the flip side of that, not necessarily because the soft tissues are normal does it mean that the tooth is a candidate for vital pulp therapy. Conversely, if you look at the soft tissues and you see something that looks like this, the parulus and the pustule and swelling, you know that is a sign of an irreversible pulpitis. I see a kid that comes in that looks like that, and I know absolutely that is not a good candidate for vital pulp therapy. So you can look at the soft tissues and you can see that is a definitive diagnostic tool. When we look at the soft tissues and we see the soft tissues are looking like that, then we know that we cannot accurately go in and do a vital pulp therapy. Also, when we look at our pulpal diagnosis, of course, we need to look at our hard tissue. So what does that mean? That means we need to look at the hard tissue. We need to look at the tooth structure. We need to see that tooth is restorable. So we've got enough tooth structure to restore. Otherwise, why are we doing vital pulp therapy? So a root that gets left behind like this, that has no clinical crown left to it, that may still actually be a vital pulp. Yet there's nothing to build your restoration on. And why on earth would we save something that looks like that? Similarly, we have a lot of root tips that are left behind here, some that really should be removed. You can see the eruption of the permanent incisors to the labial of these root tips. But these other teeth, the lateral incisors and the cuspid, they could considerably hang around for a longer time, but again, not too much root structure left behind. So again, that is a definitive diagnostic tool when we look to see the hard tissue left. The other thing that we look at in our clinical diagnosis is a radiographic analysis. So that radiographic analysis, what it is that we're looking for is we're looking for several things to see if the tooth is candidate for vital pulp therapy. So the first thing that we're going to look at to see if there's any radiolucencies. Do we want to see if there's any radiolucencies? For an anterior tooth, we're going to look primarily at the apex of that tooth for radiolucencies. For a molar, we're going to look at that furcation for radiolucencies. We're going to look at the ligaments. Sometimes we get so focused on that radiographic analysis and that clinical diagnosis that we forget to look anywhere except for radiolucencies when we're looking at a tooth to see if it's vital or not. But we need to look at that ligaments. We need to see if there's continuous ligaments or if there's discontinuous ligaments, if the ligaments are healthy. We need to also look at root resorption, both internal and external. Any signs of abnormal internal or external root resorption are indications that tooth is not a candidate for a vital pulp therapy. And finally, time to exfoliation. And this is something that's very subjective, the time to exfoliation. The clinical recommendations tell us that we should have 2/3 of the root remaining in order for us to carry out a vital pulp therapy. But there's so many other factors that come into play. There's the age of the child, there is the progress of the other teeth towards exfoliation. Is it an aesthetic zone? Is it perhaps a molar that is holding space that's critical? So many things that come into play. Is the child fearful of the procedure? So many things. So radiographic analysis and all of these radiographs that you see starting on the left-hand side of your screen, where we're looking at the anterior teeth. We want to look towards the apex typically to see if there's any radiolucencies around the apex of the teeth. And when we have teeth that are exfoliating, sometimes it's hard to tell what's going on in that radiograph. When we look at the molars, you see the darkness, the radiolucency underneath that primary molar on the middle top of your screen. And then time to exfoliation. So, very obviously, there's a shell of a tooth left here. There's not any pulp left at all on the bottom center of your screen. And then on your right-hand side of your screen, we look to see the internal, external resorption, time to exfoliation, and whether or not it's worthwhile to treat that tooth. And so we want to know that clinical diagnosis of the radiographic analysis is a definitive diagnostic tool. So we know now where we're going through this pulpal diagnosis flowchart to determine if it's vital pulp, and we can have a normal reversible pulpitis. So the summary is that pain that is induced, that is daytime, that is transient, that is relieved, those are all indications that are more indicative of a reversible pulpitis. And note that I say it's more indicative. It's not a definitive diagnosis. Indications that the tooth may be treated successfully with the vital pulp therapy. So the clinical diagnosis, as I've just gone over, the summary here is that the clinical diagnosis needs to find normal soft tissues, a restorable tooth, and those are requirements for successful pulp therapy. So those are requirements for successful vital pulp therapy. The radiographic diagnosis, the summary is that it's a normal apex for an anterior tooth, a normal furcation for a molar, either must have more normal ligament, normal roots, no internal or external resorption, a reasonable time to exfoliation. Those are all requirements for vital pulp therapy. So when we're going through our flow chart, when we're getting down to the caries removal, so we've determined we've got a normal reversible pulpitis, yes, and so we have now two options. We never had two options before. Now we have two options. The first option is caries tissue removal. That's traditional dentistry. And so in that option, we're looking at how are we going to remove the caries, and the green, yellow, and the red are there for a reason. It's not just there for color. The green is what's recommended. The yellow is proceed with caution, and the red is recommended against. So recommended is to do selective caries removal in our treatment of the pulp. And if and as I said before, we've never had this other option before where we had no caries removal as an option. That's new, new and not new that it's in the recommendations here. So no caries removal would be something like a Hall technique. So that's the placement of a stainless steel crown without the removal of any caries, which has proven to be very successful and has been studied quite a bit over the last several years. So that would be a possibility. Maybe in the future, maybe we're going to be looking at this when the next review is done. Maybe that might be the only thing that's recommended in green. Who knows? It certainly seems to be the way things are going and our world is going in dentistry and in caries removal. So we look at our caries removal, which is still typically our standard of care, and we want to do selective removal. If we can do selective removal and we can have no caries exposure, no pulp exposure, not no caries exposure, we have no pulp exposure, then we're going to have the very best success at our treatment. Let me explain that further. So as I said, I want you to pay attention to the colors that are on here so that you can see what the recommendations are for our treatment. So the recommendations are green, strongly recommended, yellow is conditional, and the conditional recommended against is that light red, and strongly recommended against is the brighter red. So those are our options for our caries removal. And what we want to do is we want to stay to the green. So selective caries removal that does not result in a pulp exposure. Now, cut to the chase to the end of this study. And this is the punchline. So this is the end, the conclusion. I'm still going to tell you how you get to the conclusion and what you're going to do. But the conclusion of this study is that the best thing that we could do for our kid is to have a primary tooth that has no exposure, and we are going to do an indirect pulp therapy. That's going to give us our very best chance of success. It's going to give us the least amount of time in the chair, and it is going to give us the best result. So further to that, we're talking about some pulpotomies, which I'll talk about in a few moments after we talk about the indirect pulp treatment. So conclusion is that indirect pulp treatment is likely to increase the vital pulp therapy success over other vital pulp therapies. So ignore the rest of the words for now. Indirect pulp cap, because we need to digress. I need to digress, and I need to tell you what an indirect pulp therapy is and how it is that you're going to do it. So an indirect pulp treatment, cap therapy, and for the purposes of tonight's webinar, you can use them all interchangeably. I will use them all interchangeably. So we are going to talk about when the tooth has no pulpitis or the reversible pulpitis, the deepest carious dentin is not removed to avoid a pulp exposure. And so we're leaving some caries behind. So again, this is something that is not something that we would typically have done in the past. In incomplete caries removal didn't have a lot of evidence behind it. Now it has much, much more evidence. So indirect pulp therapy, leave the deepest caries behind. And then what we need to do is seal the decay with a material or crown to minimize microleakage and stop the caries progression. So our materials have gotten so much better. And the evidence, as I said, is coming. So this study is from 2008, so a fair bit ago. And in 2008, it's telling us that we can have the incomplete caries removal on the basis of the studies cited in that review. You can state that there is substantial evidence that the removal of all infected dentin in the deep carious lesions isn't required for successful caries treatment, provided that the lesion can seal completely. So, and that's key. So sealing completely, when we are looking at this, we were often looking at a stainless steel crown, and now we have other options besides stainless steel crowns. So hold that thought. You look at this other study closer to present day, 2018, and you see the conclusion here on incomplete caries removal is that partial caries removal can be considered a treatment option in deep carious lesion management in primary and permanent teeth. And so this is now giving us more evidence, and there's lots more out there. So when we do that, how are we going to do our indirect pulp therapy? Well, one way is to do a silver diamine fluoride application. And a few of the silver diamine fluorides that are out there and available on the market today, we have the Advantage Rest, we have our Silver Sense, and we have our Rivastar Aqua. So all of these are silver diamine fluoride composition compounds, and they're topical agents. They arrest dental caries, and we can place them onto the tooth in question and arrest the dental caries. That is an indirect pulp therapy. So that's one option, is with silver diamine fluoride. It looks like this. So this is Advantage Arrest. This is a 1-year post-silver fluoride placement, silver diamine fluoride placement. And what it's doing is it's arresting the caries so that we do not have any invasion of the pulp. So that's one option. And so we have the indirect pulp therapy, which is recommended. The other option is to put a medicament onto that area. So we have several different medicaments that are available to us in order to do an indirect pulp therapy. Now, when would I choose to put a medicament on, and when would I choose to do a silver fluoride? So if I have a silver fluoride candidate in my diagnosis, I'm far enough away from the pulp that there's not going to be any communication. And I can arrest that caries before it penetrates and touches the carious lesion. If I have an indirect pulp therapy and I'm closer, then I would rather do a medicament there. So I'd rather put a medicament onto that tooth so that I can help to regenerate that pulp, and I can help to recreate the regenerative dentin. And so the choices would be a TheraCal LC, the TheraBase. Those are both Bisco products, and those are calcium, resin modified calcium silicates. Differences between the two, I'll tell you in a moment. And then on the bottom row are some other MTA-like materials, biodentine, and the Neoputty's Neo-MTAs. The differences between the top row and the bottom row is that the top row, I can put these materials on, I syringe them out, just what I need, I hit a light to it, and I can carry on with the procedure. The bottom row, they all take time to set up. So if I have any hope of doing a composite resin restoration or an indirect restoration, or pardon me, a direct restoration at the point of the appointment, then I need to use one of those top materials. So TheraCal LC we'll look at first. So again, that's from Bisco. If you're in Canada, it's from Curion, and it is a light cured resin modified calcium silicate pulp protectant and liner. So we're going to put it on to a deep area where we have a lesion. So you've got, so I'm prepping the tooth on the right-hand side, and I'm removing the decay. You see, I've got it, you're not looking in a mirror there, that's double dammed. I'm doing the quad number 2 and quad number 3 together at the same time. We're in the operating room, so we have that double dam on. I've got a big round number 8 burr, and I'm taking out the decay. As it's getting deeper, then I'm getting close to where I might have an area where I'm concerned. So I'm in there with the pulp, with the Explorer to see if I have an exposure. I do not have an exposure, but I need to protect that pulp because I'm quite deep. So I'm going to go in there, and I am going to do some TheraCal LC into that tooth so that I'm protecting that pulp. So I'm going in there now, and I'm finishing the prep for a stainless steel crown just before we put the TheraCal LC. So on our second screen now, the TheraCal LC, so you can see it's just a syringe, and we syringe it out into the area. If you keep the area slightly moist as you're syringing the material on, the TheraCal LC is going to stick better. Light cure material, hit the light to it, and carry on with your procedure. So this is an indirect pulp therapy. Now, if you look at your direct, and another choice for an indirect pulp therapy medicament is the TheraBase. So again, from Bisco and Curion, this is a dual cure as opposed to the TheraCal LC, which is just a light cure. So this can be put into greater depths. It's got stronger physical properties. Both of these materials release calcium and fluoride, but this one is a self-adhesive. So if you have concerns about your TheraCal LC flaking away, then you choose your TheraBase. So TheraBase, again, better physical properties, bondable in greater thicknesses. It has a calcium release, but it's not for exposures. If I would have an exposure, I would rather use the TheraCal LC. That the chemistry is better for an exposure than the TheraBase is. If we have large increments, we place the TheraBase. So you take a look at a deep lesion. This is a 6-year molar. I know I said this was all primary teeth, but this is a young permanent tooth. And we have a deep lesion. I want to have some more strength because I'm going to build composite over top of here for a restoration. And so I can place my TheraBase if I want to have an increased strength on that. So an indirect pulp cap. So this was interesting. This is Journal of Dentistry 2024. Clinical and radiographic success of 3 bioactive endodontic cements in primary molars. So 86 teeth over a year, which is a good time period for this to happen, study to know whether we're going to have success or not. You see the success rate of biodentine at 88%, which is still great. Theracal PT, which I'm going to talk about in a minute, is 88.5%, and Therabase had a 100% success rate. So very, very promising. If we go in there and we've got complete caries removal, and or even if you're close to complete caries removal, sometimes it's just partial caries removal, you have a pulp exposure, then we need to look at a direct pulp cap. So now we see red. We've got a pinpoint exposure. And we want to be less than a millimeter, particularly when it's a primary tooth. We can use a direct pulp cap and then again seal it with a restoration that is going to cut off the oxygen to that tooth and to the lesion rather. And so we want to do that very cautiously with an MTA or an MTA-like material. The evidence is still telling us that we're better off doing a pulpotomy than a direct pulp cap on a primary tooth. So that brings me into a pulpotomy. So indicated when caries removal results in a pulp exposure, or it can be a traumatic removal, traumatic injury, results in a pulp exposure in a primary young permanent tooth with a normal pulp or reversible pulpitis, or after a traumatic pulp exposure. So we're going down our line here. We've got our pulp exposure, pulpotomy. Remember, that's green, so that's recommended. And then the materials, or the medicament rather, or both, that we would be most successful with are the MTA or the biodentine materials. And then followed by formicresol, which we shouldn't actually be using at all, ferric sulfate, which is even worse, track record, zinc oxide, eugenol, sodium hypochlorite, and then calcium hydroxide is at the bottom. So we should be doing our pulpotomies when we do them with an MTA or MTA-like material. You go back to that use of vital pulp therapy article that I've been talking about, and the pulpotomy methods, medicaments, and conclusions tell us that if we are using formicresol pulpotomy, lower success rate compared to MTA pulpotomy at 24 months with a high certainty. The better alternatives are an indirect pulp therapy, which we just spent a whole bunch of time talking about, or calcium silicate cement pulpotomy, which are any of these materials, or MTA itself. So biodentine, which I do use, and Theracal PT, which I'm talking about today, and Neo-MTA, which I do use, Neo-Putty as well. So let's look at a pulpotomy procedure. This is the first primary molar that I'm going to do a pulpotomy for. So we have our clinical photograph, preoperative photograph, followed by our preoperative radiograph. So this is the lower molar that we're doing. And you can see how close it is to that pulp horn that's coming up in the center of that first primary molar. You're less than a millimeter away on the radiograph. Remember, flat image, 3D surface. So what I do first when I do my pulpal therapy is I'm going to do prepare the crown first. So this child is going to have a zirconia crown. So I've prepped the tooth for the crown, hence the bit of hemorrhage there. Then the next thing that we need to do is we need to remove the pulp chamber, roof of that pulp chamber. So remove the roof of the pulp chamber, and now I've got to get out the coronal pulp material. So there's 2 ways to do that. I can either do that with a spoon excavator, or I can do it with a big round burr. Either way, you're going to have the same result in terms of success. So if I do a big round burr, it's a little bit faster than a spoon excavator. So I prefer a number 8 slow speed round burr. And now I've got to get some hemostasis. So I got to get some hemostasis on that tooth, and I'm going to do that with a cotton pellet. So a cotton pledget. I'm going to soak that cotton pellet or pledget in some saline. I'm going to irrigate the tooth chamber with some saline, and pressure is going to cause the hemostasis to happen. And now hemostasis has been achieved. Typically should take about a minute to achieve hemostasis. And then I'm going to fill chamber with my medicament. In this case, it is the Theracal PT. So the Theracal PT, again, a Bisco product, and this is a dual cured resin modified calcium silicate pulpotomy treatment. So all in the same family of what I've been showing you of the Theracal LC, and the TheraBase is the Theracal PT. So again, dual cured. So I don't need to worry about this if I'm very deep, which of course I am, because I'm way down in that pulp chamber. I am going to place my Theracal PT right down to the bottom of that pulp chamber. And then I am going to fill the chamber. So I want to have about 3 to 4 millimeters of material of the Theracal PT. That's what the evidence is telling us, that the MTAs and MTA-like materials should be about 3 to 4 millimeters of thickness of our material. So 3 to 4 millimeters, and then I'm going to light cure that, and then I'm going to carry on with the cementation of the crown. So this is the zirconia crown. It's pink. It's a try-in crown. This is not the one I'm cementing. This is trying in for size. And then once my size is good, this is the actual zirconia crown that is cemented in place. And this is the child in occlusion. So immediate post-cement tissues are still looking kind of yucky. So when we look at this, the biocompatibility and bioactivity of dual cured resin-based cement, again, this is a newer study, 2024, from the Journal of Endodontics, and study aimed to assess that biocompatibility and bioactivity of the dual cured resin-based calcium silicate, the Theracal PT cement, both in vitro and in vivo. So they looked at the Theracal LC, the Theracal PT, and ProRoot MTA, which is a self-cure MTA. The conclusions are that within the limitations of that study, the biocompatibility of the Theracal PT could be compared to those of the ProRoot MTA. So it's got really good press behind it, and it is really good at giving us good clinical evidence-based results, which is what we want. So I have a few videos to share with you. What I'm doing in this one, I'll talk through them because there's no audio besides my voice. So this is a stainless steel crown prep. So what I'm doing here in this stainless steel crown prep is I am doing my occlusal reduction first. And what I'm going to do is do about a millimeter reduction. And I always like to do my stainless steel crown preps before my pulpal therapy, because I don't want to shoot out the pulpal therapy material after I have prepped the tooth. So stainless steel crown prep, a millimeter all the way across. This is a coarse diamond burr. And then what I'm doing after that is I'm now beveling. So I bevel the buccal and I bevel the lingual, and that's so that I can snap my crown down. And then after that's beveled, what I'm going to do is I'm going to do my interproximal reduction. So I've got my fine tapered diamond burr, and I've got that interproximal reduction, and then I am going into the distal here. So for all of those of you that say that you cannot do a stainless steel crown on a last tooth in the mouth with a rubber dam on, you absolutely can, and you absolutely should. So I make sure that I've got no ledges, and this is real time. I mean, I'm not stopping. And you are getting an actual, this is actually the procedure in the mouth. So that's the first frame. Second frame now. So I'm going now, and I'm going to remove the coronal roof of the chamber. So this is my second primary molar again. I'm taking my caries out first. So I'm back to my coarse diamond burr, and I am making sure that my outline is going to be clean. I don't want to leave any caries behind. This is not minimally invasive dentistry. So I'm taking all my caries out, and I am now taking away the roof of the pulp chamber so that I can see the entire chamber. I want to be able to see the canals of this tooth so that I can go in there and I can actually clean them out and see everything that I need to do. So I'm in there, roof of the chamber off. You can kind of feel it when you're through. Have a light hand. We don't want to go deep, and we don't want to perforate through. So the next frame. So now we're into There we go. So now we're into the coronal pulp, and you can see a good healthy pulp there, because you can sort of see that it's still in this little sac. And so I'm in with my big round burr, and I just amputate out that coronal pulp. I want to just point out something here. So on the buccal here, you can see my mirror, and I'm just retracting. So I have a slot on the dam. I'm retracting, and what you see here, this is the soft tissue from the first primary molar, excuse me. So you know that first primary molar is going to be extracted. That's coming next. So now I've got remember I was just in with my big round burr, and now I've got to get hemostasis. So these are saline soaked cotton pellets, and I've got some pressure going here. While that's creating some pressure, what I'm going to do is I'm going to go in and I am going to start fitting my stainless steel crown. So I'm going to fit my stainless steel crown, trial and error. We're assuming we know the size of the width, mesiodistal. When we're happy, we flip that crown off. So that instrument's called a T3, so like a cleoid discoid. So we flip it off. And at this point, we should be fairly happy once we're ready to go ahead with the crown. I'm just tipping it. That's a crimping plier so that it's straight. And again, the rubber dam is still on. I see how many times I've dropped things in that child's mouth and it doesn't go down their throat because I've got the rubber dam on. So back to the pulp now. So now I'm going to take out the, sorry, I guess I'm still fitting my crown. So we're in the operating room here. So still fitting the crown here. So I've crimped it, and I am going to eventually get to the rest of the pulp in just another minute. I think we're done crimping it. So we're happy with it. By now, the pulp should be, hemostasis should be achieved. So I'm taking out my cotton pellets. And so the cotton pellets are out. That's a clean cotton pellet. I'm making sure that I've got hemostasis. Now, remember, you've got to have hemostasis, but you're still going to see red. So it should not be actively bleeding. If you see a little bit of red around the Theracal, PT is going in right now. And it just gets out of focus a tiny bit when it tries to hit the tooth and then the instrument. So a little bit of oozing is not bad. If we have active bleeding, then that's bad. That's a sign of a hyperemic pulp. So a little bit of red is okay. So the cement is now going to be in, and we're going to cement the crown. We're going to take the rubber dam off. So we're going to now fill my crown with some resin modified glass ionomer cement. But before I do that, I want to take out my first primary molar because I don't want to dislodge my cemented crown. So now this, as I said to you, this is in the operating room, but this procedure we done in the office, millions of times. This is awake dentistry too on a cooperative child. So remove the tooth. Now we're going to fill our crown with some glass ionomer cement. So fill it with glass ionomer cement, and then we're going to cement it. And as it's going down, I'm going to take the clamp off, and we're going to clean things up with the cement, and that's going to be the final procedure. So make sure that we're down all the way, and then rubber dam forceps are going to magically appear from my wonderful assistant, and we're going to take that off. So I'm getting short on time. I want to show you the difference between that and a hyperemic pulp. So this tooth here is going to be a hyperemic pulp on the left side of your screen when I get my hand out of the way. See how much that is bleeding? That's not oozing. That's not a tiny bit of blood. That is a ton of blood. I try and stop the bleeding. I go back in a couple more times with a big round burr. I've got some saline. It's still pretty actively bleeding. It's not going to stop bleeding. We'll cut to the chase because we could watch it for another minute, but let's go to that second video. In that second video in the middle panel, you can see that it's still bleeding. And now we're ready. Let's get this tooth out of here. So some local anesthetic on the infiltration. This kid is already, again, this is in the operating room, but this would be true to life too. and then back in to take that tooth out. So I call these dam extractions because I don't bother taking the dam off. So this is the same instrument I used to luxate. This is a luxator. This is an LM Slim Lift. So this is from LM Dental. So if you're in the States or Europe, I'm not sure where you're all from, you get this from LM Dental. But if you're in Canada, Curion carries these as well. So that's an LM Slim Lift is the elevator that I use. And then make sure that you've got good movement. And we're going to just get that tooth right out of there with the clamp. They don't get to take the clamp home, though, with them when they go home. So that is our pulpotomy. Now I just want to mention, because we're getting a little short on time, restorations. Full coverage, intracoronal versus extracoronal. And we have evidence telling us that if we do a pulpotomy, an indirect pulp therapy, a direct pulp therapy, if we can seal that tooth accurately, we're going to have the best of success. But now things are changing a little bit. It's not necessarily all of the full coverage that we need to do, whether it's stainless steel crown or whether it is a zirconia crown. Or on the bottom right, these are brand new in the States. These are from Directa USA. Those are called ceramere crowns. So those are made out of resin. So brand new, a thing for us. And whether we're doing any of those, then we're going to have success. But newer in the literature is the Activa Bioactive. So Activa's remineralization actually will support the seal against microleakage and increase mineral density of surrounding tissue. So Activa's from Pulp Dent, and Pulp Dent has been telling us this for a long, long time. But now we have some more evidence that is in their favor. So this is an in vitro study. This is brand new from the last issue, December 2024 of the Pediatric Journal, an in vitro study to compare the microleakage of the bulk fill restoratives. So specifically Activa, and it had a highest proportion in this study of leak-free samples. So it is promising to be an alternative to preformed metal crowns or for our aesthetic crowns for microleakage resistance. So Activa is great, and it is giving us, I will show you one more clinical series of photos, and then we'll get to a Q&A. Actually, let's show you the video here. So this is, not sure if you can hear me over the video. So I'm just gonna let it explain it all. There you go. So that was Activa, and you get a bonus stainless steel crown to look at. The prep for. Thank you for your kind attention once again on Viva Learning webinar number 18. I think there's some questions. And chat, there we go, Q&A, got them, bingo. Okay, let me start at the top, not the bottom. Okay, the first question I think was a long time ago. I was talking about primary teeth. I'm not sure what you were talking about, so you're gonna have to ask it again. Then there was a comment, I leave the dentin moist and still therocal is falling off. Okay, so if your therocal LC is falling off, so moist means that you're going to wash your tooth with your air water syringe. And then moist is take your high volume suction and put it over top of the tooth and then take it away. Moist doesn't mean that it's got visible water on it or visible moisture on it, but slightly moist. So I would think that maybe that your challenge is that it's too moist. Does the light cured material irritate the pulp? It does not. I do have evidence on that talking about the resin modified calcium silicates and the chemistry that is in this particular resin modified calcium silicate will not irritate the pulp because you're talking about the resin. So cured resin of this material will not irritate the pulp. Just didn't have time to show every single piece of evidence we have here. So use Paradex, not saline. So Paradex as an irrigant, so chlorhexidine you can use as an irrigant as well. You can also use sodium hypochlorite as an irrigant as well. So those will also work well. So yes, so somebody's asking, you don't want to stock saline for pulpotomy, fair enough. Do not use local anesthetic as a substitute because you are then injecting into the pulp, right? Well, and I know you're not injecting. I realize you're asking me if you can rinse with it, but you're still exposing that child to more local anesthetic, and we want to be wary of what is absorbed and maximum dosages. It's an expensive alternative. Get some sodium hypochlorite or get some saline. Dical is not recommended anymore. Dical is calcium hydroxide. The calcium hydroxide, there's just simply better alternatives for our pulpal therapy than calcium hydroxide. Yeah, why would we need pulpotomy procedure if Hall Technique stainless steel crown has a higher success rate? I mean, that's an excellent question. And my answer is that we are still stuck in the evidence, and at this point our recommendations are still telling us that is not the standard of care. And will that change? Maybe momentarily, maybe it will. I can't tell you when, but we look at the evidence and we see these techniques with stainless steel crowns and indirect pulp therapy and no caries removal having very high success rates. So perhaps this is the future. I think it may be. Thank you for an excellent presentation. Thank you for saying so. Appreciate it. Can you use Theracal PT for direct or indirect pulp caps on permanent teeth? Yes, you absolutely can. And really, okay. I'm surprised at the next comment that your Activa isn't holding up well in comparison to composite. So you're doing isolation, you're etching. I'm assuming you're bonding, Futura bond, yeah. Any tips? Okay, my Activa is holding up really well. So I am isolating, I am doing selective etch, and I do use a bonding agent. When you're doing your Activa, make sure that you're backfilling. Perhaps you're getting voids in there. Might be one thing that could be happening. I don't know. And then make sure that you have your proper increments. I'm not sure what else to tell you without seeing exactly what it is that you are doing in person, but that's what I can tell you now. And you know what? Come and do one of my hands-on courses, and we'll do them together. So I think that I've made it to the end of the questions, unless there's something else coming in. I don't see anything else coming in. So once again, thank you to Viva Learning. Thank you to Bisco for their support of the event. And thank you to Trung behind the scenes for making this all work and making it all look great. It's always my pleasure to do these for you. And I will now sign off and wish you all a good night or a good day. Thank you for joining me.